want to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Thank you for joining me this week for another episode of Fridays with Faisel. I believe that everyone deserves access to quality primary care and should be treated the same, regardless of their ability to pay. What would Medicare Advantage for all look like? That's the topic for today. So let's get started. Robert, how are you?
How's it going? I'm
It's
doing
good to
well.
see you.
It's great to see you too.
I'm so excited about this topic. Obviously, when we're talking about healthcare, and I live in the full risk Medicare Advantage world, and many times people will come to me and they'll say, well, Faisel, your average patient's 72, 74 years old. Medicare Advantage only works for the elderly. And I hear all sorts of different things. Medicare, Chen Med, and you all just cherry pick the poor, the sick, and the elderly. and I said, yeah, we sort of do. We do.
Yeah.
What would it look like for a population of people who aren't medically complex?
Yeah.
And so today we're going to be talking about that. I'm excited.
Yeah, I think it's a wonderful topic. I think it's very timely. I think we had an unfortunate debate performance that didn't really talk about the issues that people care about this week. So I think it makes sense that we want to cover it, particularly on this Friday. And when I think of Medicare Advantage or Medicare Advantage for all or a Medicare Advantage public option, I think about extending coverage for people who don't currently have health insurance, so giving them a route to actually obtain that and therefore access to primary care services. But I also think of actually helping out people who might be in a small business who have difficulty accessing employer-sponsored benefits, or I also think of people who might want to start a startup or be creative or do something else where they want to access some sort of healthcare insurance, and some sort of public option might be very beneficial for them. And I think what's really important to notice is that we talk about the extension of coverage. Somebody has a pool of money. At this point, about 50% of healthcare in the United States is offered by the federal government through Medicare or Medicaid in the first place. And I think Medicare Advantage is one of those really main ways in which that's happened. And what we can see if we pull up a little chart here is, we'll see if the chart comes up. There's a chart that's going to pop up here in a moment that shows how Medicare Advantage has actually grown substantially over the past probably 10 years or so. And this is kind of, if we talk about Medicare in general, we talk about sort of traditional Medicare, which is a fee-for-service system, patients enroll, and then we have Medicare Advantage, which is actually the program administered by private companies. And one of the things that I think we all agree about here is that it doesn't necessarily matter too much who actually has that pool of money. What matters is what happens on the ground for the patients. And so Medicare Advantage plans have been able to more effectively implement value-based care over the past 10 years or so because they're incentivized and at risk for what happens to their patient population. So they're able to be more active and more innovative when it comes to what actually happens on the patient level.
That's right. And you're right. It's a good point about half of all the healthcare billing being through government plans. And everyone quickly thinks of Medicare and Medicaid, but we forget about the VA, we forget about TRICARE, we forget about public health. Half of all of this is already managed by the government.
Right.
And the fee-for-service world. So we're talking about value-based care, which exists mostly in the Medicare Advantage world, versus fee-for-service. 95% of healthcare in the country is fee-for-service. It's transactional. There's a CPT or a billing code attached to all services. And so by its very nature, it is a very reactive model. There is no incentive for prevention or early intervention in the fee-for-service model. I think that's why you have 200,000 primary care doctors in the country, 800,000 specialists. We've got this entire system we have today. But before we talk any further about Medicare Advantage, we got to introduce our two guests. We got two special guests.
Absolutely.
We have Dr. Nehal Giwala joining us again. Hey, Nehal, how's it going?
Good. How you guys doing?
Doing really well. You see that you're in the clinic?
Yes. Home base, but I'm happy to be here. Still taking care of patients today, but it's a pleasure to be back.
I can't wait to hear, the country's talking about how to make the transition from fee-for-service to value-based care. We've got Dr. Nehal Giwala. He's like, I'm doing it already. I'm already in the full risk space. So I can't wait for you to share some of your insight with some of the impacts you've been able to make in the full risk model. Because we do have some patients who are under the age of 65, believe it or not. So I'd love to talk a little bit about that with you. And we also have another special guest who just this week, someone I'm a huge fan of. I every day watch his whiteboard videos, and I remember it was one of my probably be like a life goal of mine. That try to make sure everyone has access to healthcare, do whatever I can to help people, educate people on value-based care. And then I had one, get my name on Eric Bricker's whiteboard. And that happened this week. Check. So welcome, Eric. Welcome.
Hello. Thank you so much for having me. It's a pleasure. Thank you, everybody, for watching.
Oh, I'm so thrilled to have you come join. And actually, I saw Eric's video a couple days ago on what would Medicare Advantage for all, just even introducing that topic. And I thought, so great. And I sent him a message. I said, hey, Eric, I loved your video. Would love to have you come join. And he's like, sure, let's do this. And so the idea behind this is I loved in the 1990s listening. I loved the AM talk radio, and I love coffee shops. And I thought, especially now these days with COVID, we can't get together anymore. Yesterday, we had 2 presentations at the FMEC, which was incredible, but it was done in a virtual manner. And I just think, oh gosh, I miss just being out and meeting people in person and all. So this forum on LinkedIn, Twitter, and Facebook, to be able to just talk shop about how to increase access, I just love the forum. So thank you, Eric and Nehal, for joining us today. So before we get into talking about Medicare Advantage for all, Robert, I think we should delineate some of the differences between Medicare versus Medicare Advantage.
Sure. And I think we have a nice chart to do this too. Let's pull up that chart.
We're getting pretty fancy.
We are getting fancy. So we're just here to, and thanks to CB Insights for this graphic that I found on the internet. But what is a big difference between traditional Medicare and Medicare Advantage is sort of the responsibility and who actually is managing the pool of money. So in traditional Medicare, somebody turns 65 or otherwise becomes eligible and they sign up for Medicare, and they're able to just get benefits that are administered through the traditional program, which is a fee-for-service system for the most part. There's been some innovation going on over there with Medicare shared savings programs and different innovative models, but for the most part, Medicare just pays in the fee-for-service model to healthcare providers. Medicare Advantage plans, however, kind of sit in the middle. They're private organizations, and they offer basically similar health insurance, just like employer-sponsored markets. So people who become eligible for those services can sign up with a Medicare Advantage plan. What ends up happening here is that the insurance actually looks very similar to what it looks like in an employer market. And Medicare Advantage plans offer sometimes additional benefits to attract people to them. They have utilization management, so they have people who are actually monitoring and watching what's actually happening with their patient population because they're at risk. And they're at risk because they receive capitated payments from the government per enrollee that they have in their plan. Well, a lot of the benefits here, though, come because they're at risk for this population. And so that's where a lot of innovation can occur with payment in terms of implementing value-based payment models and full risk. They also have some innovative care management programs to better sort of coordinate care for patients. And a lot of this stuff really doesn't happen as frequently in traditional Medicare. And what we want to talk about today specifically, and this is what ChenMed operates under, is a full risk model that can be implemented, actual value-based care that is being done in the country through Medicare Advantage plans. And so the goal here is not to worry too much about who's managing this pool of money, but it's to worry about how they incentivize healthcare providers on the ground to actually provide better, more effective care at lower costs and better quality to patients. So that's it. I'll stop there.
Great. I think that was a great comparison that you just made, and I love the graphic. I think this is going to be a game changer for us throwing up graphics like that. When we're talking about one of the main differences between fee-for-service and value-based care, remember that half, at least prior to COVID, half of all medical care in the country was delivered in the emergency room setting. So we as a country are already paying far too much for services. We're paying $10,000 for $10 pneumonias every single day. And when we're talking about waste or medically unnecessary procedures, I remember when I first got into value-based care, I remember first thinking that, well, we're talking about what's medically unnecessary. It's unnecessary specialist referrals or overprescribing brand name drugs when their generic drug equivalents are available. But those two are actually a distant second and third place to the leading cause of waste in the country. The leading cause of waste in the country is unnecessary hospitalizations, fueled by unnecessary emergency room visits. I don't know, Eric, if you have in Texas the standalone emergency rooms, but all over Tampa and in Florida, I mean, they're just popping up. Standalone emergency rooms, and they're able to bill at ER rates. And so when we're spending, if you just zoom out, before we get into if you zoom out and you see that for a country of 330 million people, with 15% of the population over the age of 65, the truly medically complex, the average American only being 37 years old, we're spending $3.6 trillion, more than $3.6 trillion. So for the people who are over the age of 65, the country's spending over $1 trillion. And now medically unnecessary procedures, or the waste, which has been well documented for years. I remember the first time I read about it was back in 2008, when we had crossed the $700 billion mark for medical waste. This past year in 2019, we crossed the $1 trillion mark with medical waste. It's largely driven by unnecessary emergency room visits. And then that fuels in the whole game of the hospital system. So if you took on full risk and now you're incentivized to make care efficient, you're incentivized, yes, to reduce unnecessary specialty visits, and you're incentivized not to overprescribe brand name drugs. Your main incentive is to reduce waste, which is led by unnecessary hospitalizations. Now, how do you reduce ER visits? You restore the doctor-patient relationship. You restore the trust in the doctor-patient relationship. The doctor-patient relationship used to be a sacred one before it became this financial one that we all know today. So Dr. Nehal Giwala, your patients are full risk. You're living this model. The country is debating how to transition from fee-for-service to the full risk world. And I'd like to hear some of the impacts you're making with both seniors, of course. I know your average patient's in their 70s, but we also get some duals, people who are under the age of 65, and what they lack in medical complexity, they definitely make up in social determinants. But I'd like to hear some of the impact that you've.
I would also add that you operate, Dr. Giwala, your patients often are Medicare Advantage patients. So when we talk about
Medicare Advantage,
exactly. So when we talk about implementing value-based care through Medicare Advantage, this is what happens on the ground. So tell us more about what you do for your patients and how it's changed the way that you can practice.
Yeah, so there's a lot. I mean, there's so much to discuss, and it's when it comes to patient care, first thing, keeping, we want to take great care of patients, but when it comes to costs, there's a big pink elephant in the room, and everyone avoids talking about it. And whenever we do talk about it, everyone argues about what's the best way to make sure everyone's paid, but no one ever mentions the most important thing: patient outcomes. To me, and this is kind of what we're here to discuss, what would Medicare Advantage for all look like, or what would we think it would look like? It would look like how you'd always envision medicine to look like. It focusing on caring for the sick and the needy, keeping people out of the hospital unnecessarily. The stuff that you're always taught, the stuff that your attending used to tell you in training. It wouldn't be about billing a code or a certain level of care, but what your attending used to tell you: focus on the care of the patient. That wouldn't mean physicians wouldn't be taken care of.
You just reminded me now. I gave a residency lecture. I do a lot of residency lectures, and I had an intern a couple of weeks ago start bragging to me about CPT codes he was memorizing. An intern was bragging to me. Can you imagine that, Dr. Berker? There was an intern bragging about CPT codes that he was memorizing, and I told him, you know what I said? He was trying to impress me with all these codes and stuff, and I said, "You're an intern. You need to be focused on running codes, not memorizing CPT codes." That's the world we're in right now.
But Faisel, imagine a world. Imagine, just everyone imagine with me, Eric, Robert, everyone watching, where physicians wouldn't have to worry about billing that code. They would worry about taking care of the patient because they were incentivized based on the outcome. So those who need to be hospitalized are necessarily hospitalized and taken care of appropriately. And they're sent home as soon as possible, reducing their length of stays. Hospitals would work with us to be more efficient than they already are, focusing on outpatient care and reducing those hospital stays. And then when it came to payment, everyone would win because the outpatient world, as we do an Advantage, you're incentivized to take care of the patient on an outpatient basis. And then hospitals would be incentivized for reducing length of stays and reducing readmissions. And they would all win in the system because they would coordinate care with the outpatient side, truly, as we had always hoped they would have. This would spark innovation and transformative change. The stuff that we talk about in this country all the time. And it's something that we all desire for our own families. I mean, innovation is the key. And I read Bob Iger's recent book. There's a chapter in there, Innovate or Die. That is extremely applicable here. We have to stay innovating. And people will say, oh, what's going to happen to the payments? What's going to happen to the hospitals? Well, they've got to innovate. They got to innovate because you know what? This is a system that needs to be focused on the patients. We need to focus on the outcomes, not focusing on episodic sick care. That is the issue. That is the issue here. We need to innovate. And if we don't innovate, we die.
Right. The hospitals have no incentive. The hospitals have absolutely no incentive to stop propping up these standalone ERs.
So what I think is really interesting is in order to get to the system, you do need some way to actually implement value-based care. And it can happen in Medicaid, it can happen in Medicare, it can happen through Medicare Advantage, it can happen through employer-sponsored benefits. And so, Dr. Bricker, what do you think about all this? So our goal is to get these types of models implemented, but it's been a challenge to actually do it in real life. So what do you think about Medicare Advantage coming into play here? Where do you think it fits into the employer space?
Yeah, so it really is been highly instructive. So thank you so much for listen. I'm just here to learn. Okay, I'm a fly on the wall here to learn. So I will keep this brief, but essentially you have the folks that are bearing the risk and providing the care as one organization. Okay, that essentially is what Medicare Advantage is. Now, an employer bears the ultimate risk, and there are employers that actually then quote unquote provide the care as well, and it's typically through like a near site or an on-site clinic or direct primary care. Now, those initiatives are incredibly small. It is the vast minority of employers that have gone in this direction. However, the ones that have been incredibly successful. And, the folks that are familiar with me that are watching now know that whether it is Serigraph in Wisconsin or QualMed, QualMed that's also in Wisconsin as well. And there are Amazon now. I just did a story about this, how Amazon's very first employee clinic is going to be in the Dallas-Fort Worth area. And if you read about what that Amazon clinic is going to do for the local Amazon employees, it's very similar to what ChenMed does for your patients. And I think one of the keys, Faisel, to your point about ERs, is what an ER visit really is it's a failure of access. Right? When do people go to the ER? They go at night and weekends and holidays. Why? Because they want to? No, it's because they can't access their physician. So I think the most innovative thing about the Amazon clinic that they're opening in Dallas is it's open Monday through Friday from like 7 a.m. to 11 p.m. And then it's open on Saturday too. So like those hours, and it doesn't have to be that in person for, all offices, but you can get to them on the phone. You can get to, and at Hopkins where I trained, frankly, the primary care guys, they would get mad if their patient went to the ER. They're like, why didn't you call? Why didn't you call me? We could have prevented all of this from happening. So it's incredibly small in the employer space. And so I'm here to learn from you gentlemen about how we can take the best practices of what you guys know and apply that to employee health plans.
Right. And I think, going back to the top of the topic so that we can realign here, we have this idea of Medicare Advantage for all, which is sort of a political topic. It's how can we actually extend coverage to people who don't have coverage or who have difficulty getting that coverage. But what I think we are most interested in is not necessarily, how we go about that from a political perspective, but it's how we implement models that actually improve cost and patient outcomes. And so what we're trying to argue for here is that Medicare Advantage or a Medicare Advantage type model is actually able to implement these value-based payment arrangements that then incentivize provider organizations like ChenMed, or in the employer space, like their own employer-sponsored clinics, or with organizations that provide employer-sponsored clinics to actually be at risk for those patient outcomes. And so in Medicare Advantage, what would happen is the Medicare Advantage plan might contract with a provider organization or a medical center or medical group like ChenMed, and they'll say, here's your attributed patient lives, you're responsible for caring for them. And they're able to do that because they have been given the funds from Medicare to be responsible for the care. Now, they don't offer care services themselves typically, so they have to contract and use payment to actually incentivize these changes to occur on the ground. And so that's why we like this model, because it's actually shifting what's most important, the interaction between the patient and their physician, and how we actually provide care to them. We can do all this fun stuff up here all we want to. We can provide coverage, but none of that matters if there's still a transactional reactive healthcare system at the patient level. And so this is about shifting to better care on the ground near the patient.
The incentive needs to be on prevention. The incentive needs to be on early intervention. The incentive needs to be on making care delivery efficient. And I read just this week, one of the messages I got was about geriatric training programs being shut down because they don't generate enough revenue for the hospital system. I mean, I just think about each geriatrician, how many millions of dollars each geriatrician provides in savings per patient to the hospital system, but the incentive isn't there. So the very programs that train the doctors who are looking after the most medically complex programs, are most medically complex patients, are being shut down or are in threat of being shut down because they don't generate revenue.
Right, and they have issues tracking that as well. So when a geriatrician's intervening, and saving money and keeping patients out of the hospital and improving their outcomes, there's no way of tracking it because everything is a billing code. So if you're not billing for it, and maybe you're billing for time, but maybe if that's the most you can do, you can't. There's no way of tracking that. And the key here is frequent touch healthcare. Putting a group in charge, full risk, taking care of patients and worrying about their outcomes. It's Faisel, Robert, everything that you guys have been saying. Be proactive. That is the key. Being proactive rather than reactive. Being completely responsible for that patient, seeing them often and communicating. I think there's something to be said about communication. That's something that we do pretty well here, is that we communicate with our patients. That, getting back to what it's all about. When you have an incentive-based system, you're focusing on communicating with your patient and improving their outcomes. You're getting them excellent outpatient care that they weren't getting before, and you're letting the PCP truly quarterback everything for the patient. That is opposed to fee-for-service where, patients will go see any provider they want. They will not even communicate, nor will the consultant communicate back with the PCP. In many cases, they don't even know who the PCP is. And that is the root problem.
Now you will not believe, I've read that the average doctor is now spending about 15 minutes documenting each patient encounter. We have board certified doctors who went through all the process of going to medical school and residency, and they're spending 15 minutes documenting each patient encounter. I hear horror stories about doctors wasting all this time trying to get prior authorizations and just doing all these things that are non-doctor work. Could you imagine a world where the doctors are focused on being doctors, and then you have an entire team of people who are supporting the doctors be doctors? That's one other issue that we have right now, is that you have 200,000 primary care doctors in the country. We have this rise of the nurse practitioner. I think there's like about 300,000 or so nurse practitioners, another like about probably 100,000 physician assistants. And even doctors, primary care doctors within the same office, they don't communicate with each other. With all this technology that we have available to us today, if you look at the 45 million Americans who are over the age of 65, if you made panels of 500 with all of them, connect them all with technology, you're only talking about 90,000 doctors to look after the most medically complex.
Yeah. So now I think one of the questions that or I shouldn't say questions, one of the points I want to make is that the techniques that we learn in one insurance market, like in Medicare Advantage, can be translated into other pools of money. So just like in the employer space, the employers in this case hold the pool of money for healthcare for their group of patients. Medicare Advantage plans hold the pool of money for their group of patients. And so the question becomes, how do I spend that money, get the most value, the most health out of that money, while also reducing unnecessary care, which kind of takes away from the amount of health that I can benefit and provide by changing the way that the healthcare services are provided. Historically, employers would often, and correct me if I'm wrong, Dr. Berger, but they contract with a sort of major carrier. They offer the plans to their employees, and then that carrier then is responsible for doing whatever they do, managing a narrow network, managing a large PPO network, and then trying to still often paying fee for service, but just negotiating rates rather than really innovating and trying to offer a full risk or value-based care model to those employees. One of the ways that employers, the more innovative employers, are doing that right now is they're bringing in their own clinics into their offices. They're co-locating clinics. They're trying to offer, just like Amazon is doing, like Dr. Berger explained. And so that in a way is full risk, because they're taking on the risk of hiring and paying a medical practice while also ensuring that they're trying to get the most benefit and most bang for their buck in primary care with their employees. This can be done and is being done in Medicaid, which is a federal state partnership for low income and people who can't get access to employer-based coverage or are not eligible for Medicare. In which case, there's a lot of these same techniques, which is putting the risk and incentivizing provider organizations to reduce their panel sizes and to change some of the activities that they're doing. It's not volume-based and just trying to see 25 patients a day, but actually spending time with the patient to try and actually, impact health, which it requires for a lot of these chronic conditions and some of these issues that actually drive up costs for both employers or anybody in the country.
So let me ask you, Nehal and Faisel, specifically to piggyback off of Robert's comments. So what are some of the specific things that and I'll be honest with you, I don't like using the word value-based because I feel like it misleads people, because so many people say value-based and it really is a red herring for fee for service, right? It's just kind of covering up an actual fee for service relationship. And so, it's capitation. Okay. And that's like a bad word. It was in the 90s, you can't say capitation anymore. Okay. But this is just my opinion, right? So fee for service primary care is stupid, right? So it really a capitated primary care like model, that just makes more sense. Fee for service primary care is it's ludicrous. Now, so the question becomes, what types of strategies, techniques, behavior changes do capitated primary care physicians do that a fee for service primary care physician would not do? What would be the difference?
Now let me get started with this, because you're right, Eric. When I hear, I'm meeting more and more people who are in some of the shared savings, value-based care arrangements, or some small downside risk, but they're still having to do a lot of documentation and a lot of busy work in between visits. And in many ways, the full risk model almost seems like a completely different space compared to some of these different types of value-based care arrangements where there's just shared savings or some downside risk. And a lot of the value-based care payments are still rooted in fee for service. So it feels very much, like you said, it still feels like a very fee for service type of way of practicing medicine. So in the full risk model, let's say if you pick anything, pick the flu. Pick the flu. The country right now, less than half of all American adults are vaccinated against the flu, right? The incentive is not there. And this is despite having like every grocery store, every pharmacy. In fact, Nehal, I haven't gotten my flu shot yet. Shame on me. Shame on me. Shame on me.
Come on by.
I told my wife this morning. I told my wife this morning, I'm going to the clinic to go get my flu shot. And she said, you better not. You better go to the grocery store. You can get a $10 gift card. You could tell. I provide for the house. She runs the house. But in the full risk model, when you're looking at the flu, you're looking at, and especially in our space, because right now, our average patient's in their 70s. They got 5 to 7 chronic medical conditions. They're all on fixed incomes. In Tampa, it's like $600, $900 a month. So you're dealing with like one of the most underserved patient populations. Our incentive would be to prevent the complications from the flu. And what's the best way to prevent the complications from the flu? It's with having an aggressive flu vaccination program. And now the thing is that you can get about half of any patient panel to get back, to go along with what the doctor says. The doctor says you get time for your flu shot. Okay, give it to me. But it takes a separate skill set to go up to the 60, 70, 80, 90+% range. And that's through using tools like motivational interviewing, really getting on that level with each particular patient. The doctors are incentivized to reduce the unnecessary complications from the flu by offering something as simple as a flu shot. It's really not all that complicated.
And also, if I may touch upon, I'm sorry, Robert. If I may touch upon the care team model, because that's one thing that actually helps us influence outcomes. It's a care team approach. So every physician in our organization, what we do is we actually give them an entire care team. So quarterback can't play by themselves. So physicians have to lead their care team, but that includes someone at the front desk, someone in the back desk, as I call it. You have a medical assistant, you got a nursing supervisor, you have people on your team, someone to help you with coordination of care. Suppose something's getting complicated for a patient with a consultant. So that's how we do things. We coordinate care, but we have the physicians quarterbacking it. And by doing that, that's kind of how we started focusing on outcomes. We recognize that medicine is a multidisciplinary approach. Now, most primary care offices don't have the luxury of that. They're not quarterbacking. They are the entire team. And imagine, and we all know this reality, you can't do everything yourself. You cannot. You have to have a proper care team. And even when it comes to something like flu shots, which sounds super simple, to get my patient panel vaccinated, it is a care team approach. We have people at the front desk when they're walking in, talking to the patient is a beautiful thing. They're talking to them, giving them the paperwork, educating them. When they come to the back, we're doing the same thing. For anybody who has questions or hesitancy, we work on that. And that is just with the flu shot. Imagine if they have congestive heart failure. Imagine if they have COPD. Imagine if they have a terminal illness like a cancer. And we are having a care team approach that is focused on their outcomes. We're doing what's best for them. We are still practicing medicine 100%. We still follow guideline-based medicine. We love it. But we use the care team to help work on our outcomes, because there are things that we do that that we have a lot of patient outreach. We call every patient in this office every week. It's mind blowing, but does a primary care office do that? We touch every patient every week with a phone call. Just ask him, how you feeling? Do you need any medications? We have caught so many errors. We have caught so many. We have stopped so many unnecessary hospitalizations with a phone call.
Nehal, you sound like a crazy doctor.
I know.
You expect patients to trust you with a lot if they can't trust you with a little. The American population doesn't trust their doctors even with a little. That's when they're going.
What I've gathered from working with you guys in terms of what ChenMed actually does is that high touch care model. So it is actually having more communication with the patient to be able to actually catch some of those errors or possible mistakes that could lead to something bad down the road. You try and implement like high value services like flu vaccination to be preventive in the first place. You also let your patients text you instead of going to the emergency department. You just give them access to you 24/7. And I learned that from Dr. Syed, is that's one of the other strategies that they use to better care for this group of patients. And then they also address things like social determinants of health and individual behavior. So they spend a lot of time focusing on motivational interviewing, behavior change, because they have a smaller panel size. They're not under the volume burden, so they can sit there and spend time with that patient to try and get them to alter some of their lifestyle behaviors. And then Faisel, tell us the two stories. The first one about the Coca-Cola patients, and then tell us the other story about what you did for during COVID, when it was kind of peaking back in March for your patients in terms of some of the social factors that you helped address.
You're going to get me in trouble with the endocrinologist. I remember when I first joined ChenMed, I had was one of the early patients. The patient got roomed in, and my medical assistant said to me, "Good luck with that one. You're like the fourth or fifth doctor that he's been seeing. He's an uncontrolled diabetic. He doesn't want to take his insulin. His A1C was like 11 or 12." And I thought, okay, go meet this patient who's like had a label. In the fee-for-service system, so many horrible labels for patients. Like a patient that shows up unscheduled is a walk-in. A patient who won't take the medicine is non-compliant. In the emergency room, what was it? The patients that go to the emergency room frequently are called frequent flyers. Just horrible names for patients. You can't believe that this system, it's not a broken system, by the way. The fee-for-service system is not a broken system. The fee-for-service system does exactly what it was designed to do, which is to generate revenue by billing. It is a phenomenal system for generating revenue. But when we're talking about true healthcare is this full risk model where the doctors are in charge, like Nehal was saying. The doctors are running the code. The doctors aren't the ones. The doctors are giving the orders with running. They're not administering the medications and writing down what they're focused on being doctors. There are plenty of other people in the system that can do all the other little work. So anyways, with this patient, the Coca-Cola patient, so I met this patient. He starts telling me, "Oh, I know, doc, what you're going to tell me." I walked in the room, and right away, he was just like, "I know what you're going to tell me. No sodas, no sweets, no sugar, no da, 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 da." And I said to him, "Hey, I just want to get to know. I just want to get to know you. I just want to get to know you. It's nice to meet you. I'm Faisel Syed. My background is community health. I believe everyone should have access to primary care. And let me give you my number. I want to make sure you have my phone number so that you're sound like someone who's struggling with diabetes. I need you to call me when you're not feeling well." And he was just kind of blown away by that. And I said, "Okay, so you like drinking soda?" He said, "Yeah, I like drinking Coke." And he was drinking, I don't remember if it was 8 cans or 10 cans, but it was some kind of ridiculous number of cans of Coke every day. And actually, he was one of my under 65 patients. He was a patient who was not a geriatric patient, not overly medically complex. I think besides the diabetes, maybe it was obesity. He did not too many chronic medical conditions either. But he was on a tight fixed income. So I just started talking about the economics of drinking so many cans of Coke. I said, "That's quite expensive. Why don't you buy like a 2-liter bottle of Coke every day instead of all these little cans?" And he's like, "No, doc, no. I like having the fizz every single time." Like he knew the temperature of the Coke and he wanted the experience. And I said, okay. And I said, "Well, if you had to only drink Coke a couple times a day, when would you absolutely need to have it? There's no negotiating." And he said, "Lunch and dinner." He said, "Lunch and dinner. Every other time of the day, I could figure out some other way around it, but I got to have it with lunch. I got to have it with dinner." I said, "Deal. That's a great place for us to start. Would you mind using seltzer water with the artificial sweeteners to substitute for the other times?" And he said, "Sure." I got into trouble because he went out into the waiting room and he told everybody, "I'm an uncontrolled diabetic, and that doctor over there said it's okay for me to drink Coke." The center manager came to the back and he said, "I'm not no doc, but I don't think that it's a reasonable thing for a doctor to be recommending diabetic patients to drink Coke." And I told him, I said, I had to reach an agreement with him. We had to set a realistic goal, and I had to build trust with him. This is the first time that we met each other. He's used to hearing the spiel. He said the spiel even before I could say it. No sugars, no sweet, no rice, no pasta, no bread. I mean, he was better. He's probably better at explaining what not to eat than I could probably have done. But that built the trust. And believe it or not, within a month, he stopped drinking Coke altogether. And do you know why? Because he loved the fizz more. He loved the fizz in the seltzer water more than he did in regular Cokes. And within 3 months, his A1C was out of control. It was like 11 or something ridiculous. And it came down into the 7s without any insulin. No insulin, no medication. We didn't even get that far. We were just focused on lifestyle. Because like many diabetics, he's just one of these people that was diagnosed in the emergency room setting with hyperglycemia. They put him on insulin. He's been seeing different doctors, and they've just been continuing insulin. He never took the insulin because he didn't like needles. And nobody really had that conversation about setting some realistic goals. And I think that's one of the things that really sets us apart with our approach to care in general. Before I get into our response with COVID, do you know what I completely neglected? Our comments. I completely neglected the comments. Shame on me. And I'm seeing over here, I just have a comment here from Henry. Henry, how are you doing?
You remember Henry?
Of course. Henry from Michigan. Thank you so much for joining. Peter Grimes, thank you so much for joining. Dan Ross, thank you so much. This is great. So Henry put up a great question here. Like, how would you bridge the traditional provider orgs that are in fee-for-service willing to take on the downside risk without the care delivery structure that supports high-touch primary care? So the first step is the system. You got to have the right system in place. The current system that we have in place failed miserably with patient care in general, especially when you can't bill, like what happened with COVID. When COVID hit the country, suddenly now you can't bill. Patient volumes decreased by 60 to 70%. And everyone's trying to figure out how to survive. How can you bill for a phone call? Well, the phone call reimbursement rates, correct me if I'm wrong, it's something like $6, $10 per phone call. We can do a lot of doctoring over the phone within a week. And imagine we're a high touch. We see our patients monthly as routine. So we had to switch from being this high touch, frequent touch model to completely going telephonic. We were able to make that switch in less than a week, believe it or not. And we provide the same kind of care. The incentive is there for us to love on the patients. The incentive, actually, Dr. Burker, you're not going to believe this, but Dr. Nehal Giwala is my dad's doctor. So I was at an airport in Louisiana, and my father called me. There's so much misinformation that was out there around COVID and coronavirus. And he called me saying, hey, listen, I don't know what you're hearing on the news, but I spoke with Dr. Giwala. And Dr. Giwala, he calls him Dr. G, like lovingly. Dr. G told me, as long as I stay home and I avoid going outside, if I go outside, I wear a mask, I'm really thoughtful and mindful when I'm outside, everything will be okay. So I'm just going to avoid going out to people. I'm not going to be visiting people. And this was back in, I think it was in March time, before all the restrictions happened with travel and all that. And but that's what I'm talking about. When you restore the doctor-patient relationship, incredible things start to happen. Society starts to put their trust back with the people who are the experts when it concerns health. Right now, they don't know who to trust about anything these days. And what a tragedy that the doctor-patient relationship, which for generations has been a sacred one, became this financial one that we all know today.
So,
guys, we've been live for way, way too long. This is
I think what you commented on there is the fact that and going back to Henry's comments, is that you guys were really able to keep offering your services because you were receiving this capitated sort of full risk model. So you weren't really impacted whether patients were coming in or not. You didn't have to bill. So financially, you guys were able to actually continue offering your services and just kind of shifting the way that you were able to operate. But generally speaking, when a payment change comes into play here, when you shift from fee-for-service value-based care, something has to occur operationally in a clinic, and it's very difficult to kind of shift from, I need to maximize patients coming in, I need to go through these workflows, and shifting it over to actually like completely changing the way that clinics operate and how physicians think about practicing medicine. So it is a big change culturally and operationally inside an organization. The financials, fairly simple. Quality metrics, fairly simple to figure out. But what do you actually do? When do you bring patients in? How do you train staff to do the workflows? How do physicians, how much time can you allocate to a patient? All that stuff is very, very difficult to shift. And sometimes one of the big issues with a lot of value-based care is you'll have an organization that has some patients that are fee-for-service patients that you still want to maximize volume from, and some organizations you will have some that are full risk patients, and so some you have different incentives there, and so it's very complicated to navigate.
Good luck trying to tell a doctor, okay, I want you to think like a fee-for-service doctor for this person, and the next person you're going to see, think of them like a full risk. Right, never going to happen.
You can't do it. And and also to Henry's question, I just might quickly say, and this is just my opinion, it might not be possible to bridge a traditional provider fee-for-service organization over to a a capitated model. And here's my reason for that opinion. The reason for my opinion is look, the doctor's office, it needs cash flow. It needs money. It needs access to the premium dollars. So the only way you're going to be able to successfully do that is if someone's going to be willing to give you the money up front. So, okay, who's going to give you the money up front? The Buka insurance carrier is not going to give you the money up front. Like these director primary care folks, they're trying so hard to get the employer to give them the money up front. And I'll tell you, because I spent 10 years selling employee benefits, it's an incredibly long, slow sales cycle. It'll take you forever to get the cash flow from these employers to be able to fund it. And so what you're left with is Medicare Advantage, or some sort of arrangement with like Centene to give you prepaid Medicaid dollars. But you've got to get access to the cash. And right now, frankly, there's not a lot of good options for that.
You got to be able to demonstrate it. You got to be able to demonstrate that you have a system in place, to any insurance company, that you have a system in place that's designed to improve efficiency, reduce the waste, starting with unnecessary hospitalizations. You start there, you have a system that's incentivized, you have a team of people that are incentivized to restore health and to improve healthy days, and you'll see incredible changes start to happen. But I agree, this schizophrenic way of doing things, having these hybrid models, it's just another, like you said, it's just another ugly word that turns people off. The full risk model is the way to go. Guys, I am so sorry. I can talk with you all day, and we could do this. We need to get better. I mean, we're just a bunch of people who are passionate. We're not professional TV or any of this kind of thing. We're just people that just are passionate about healthcare and restoring the doctor-patient relationship. I feel like we can do this all the time. Eric, I love that you came today. I'd love for you to come again. We try to find time over lunch to talk about what we're passionate about. Anyone who joined us, please shoot us some comments and messages for over the weekend, so we can find another topic to talk about next Friday. I think that we have a lot more that we can talk about, though, with the transition to fee-for-service, especially for the practices who are struggling because of COVID, because of decreased patient volumes and decreased reimbursement rates from telemedicine, what some options may be for you. And I'd love to get into that a little bit more. Eric and Nehal, thank you so much for coming. Eric's first time. Thank you for just being so flexible and nimble just in the last couple of days. Nehal, this is great. A lot of fun to see a doctor who's living the full risk model with the most underserved, most medically complex patient population. You're doing it already. We're going to increase access to care. It's going to happen. Everyone will end up having access to care. Robert, anything you want to say in closing before we say bye to everyone?
I think it's been interesting because I usually hang out in the government-sponsored insurance space, and I'm seeing a lot of direct primary care folks and the employer people in the comments, and obviously coming from Dr. Bricker's world. So it's been interesting to see that group really growing in their voice and trying to make some of the changes that are happening from the Medicare Advantage and Medicare world a little bit more applicable and possible in the employer space. So it's been exciting to see that movement growing, and I'm excited to continue learning more about it.
Super. Well, thank you all for joining us. For more information about today's topic, as well as value-based care in general, or the full risk model, please visit chenmed.com/resources. Healthcare is a right, not a privilege.